but also the ability to educate the referring.
The appropriate use criteria. Now in America, the appropriate use criterion were meant to be a good thing, but they turned out really to be the most evil thing that most of us in America have to deal with. But the definition of an appropriate test is one in which the expected incremental information combined with clinical judgment exceeds the negative consequences by a sufficiently wide margin for that indication of the procedure to be generally acceptable care and a reasonable approach to that indication. Now you ask, what are the negative potential? False positive test, layered testing, complications of invasive procedure as a result of a poorly done or non-diagnostic test. So these appropriate use criterion have been developed over the course of time. Myocardial perfusion imaging was the first of the tests to be applied to the AUC. 2005, again in 2009, and then in 2013 we came up with the multimodality appropriate use criterion for the detection and risk assessment of stable ischemic heart disease. And this is the guidelines by which we have begun to live by as much as possible over the last 4 to 5 years. This is a study that came from Kaiser Permanente in California, and it looked at the declining utilization of myocardial perfusion imaging. It was published as a letter in JAMA in 2014, and you can see from the peak in 2006 down to 2014, there was a 50% reduction of myocardial perfusion imaging, but it was associated with a 27% decrease in myocardial infarction, with only a minimal increase in coronary CTA or echo. So they weren't doing more tests, different tests, they were simply doing less tests. So I want to bring to light 2 terms that I think are important. We talk a lot about value. Value is really quality divided by cost. It's a population-based assessment. It's the cost of implementing treatment, and it can be variable in the population. If you study people who are not taking care of themselves and not complying with meds, okay, you're going to spend a lot more money to provide care for them than if you're going to take somebody who's healthy and active. On a personal level or on a patient-based level, I use the word valuable. Will this test help treat my patient? Is this best option for my patient? Or how will the results be used? So the appropriate use criterion were developed in the sense of value. But as a clinician, you need to look at every patient and say, what is going to be valuable for this patient? Here's an example. If you want to talk about the risk of falling off of something, if I try and jump off of this little bridge, there's very little risk to that. I don't need to do a test on that. If I'm going to jump off of this bridge, I'm going to die. We don't need to do any testing to determine that either. But if we're standing here, I need to know, is there water in the pool? How deep is the water? Can I swim? I live in Florida. Are there alligators in the pool? That's where risk assessment is valuable, and that's where myocardial perfusion imaging is important. You just saw this slide earlier from Dr. Vitola, so I won't go over it again, talking about the 10 to 12% cutoff in terms of medical therapy versus revascularization related to the perfusion defect size. A similar study showing similar results was shown in the JAXA study, which is less well known, but again the same thing. When greater than 10% ischemia is noted and patients did not undergo early revascularization, they did poorly. What do we know about real world? Because whenever we put a patient in a clinical study, we know that both sets of patients get better attention, whether it's one treatment versus another, whether it's placebo versus active therapy. These people are all being followed actively and they're being encouraged to do appropriate things. This is a real-world study that came from Rami Dukhi from Chicago, and it really looked at the difference between inappropriate tests and appropriate tests in terms of outcome. And I'll show you on the next slide that you can see that appropriate utilization predicts risk. There's tremendous risk stratification between an abnormal and a normal myocardial perfusion scan for death, cardiac death, death or MI, or cardiac death or MI. On the other hand, if you have an inappropriate test, there's really no difference in outcomes. So we know that using the appropriate use criterion are valid for patient care. Now, in order to get the most out of the study, we need to be able to supply all the information that's important. And some of it is quantitation. So it's the sum stress score, the sum rest score, the sum difference score, and the total perfusion defect, which is really very, very easy to calculate. For those of you who use a 17-segment model, the maximum score in each segment is 4. 4 times 17 is 68. You just put the sum stress score, divide it by 68, and you can figure out your percentage defect. And I recommend everybody report that in their nuclear stress tests. Once you do this quantitative or semi-quantitative assessment, we can come up with the maximum ability to risk stratify people. Now, this comes from the American College of Cardiology document on indications for coronary revascularization. And up here is what you can see are the high-risk findings that are really all appropriate for coronary intervention. Now, high risk is defined by greater than 3% annual death or MI. And the information that can be gotten from myocardial perfusion scan are resting LV dysfunction with ejection fraction less than 35%, resting perfusion abnormalities without a history of a prior MI, abnormal exercise EKG responses, severe stress-induced left ventricular function, particularly if you're doing rest stress imaging or if you're doing PET where you can do easily get rest and stress exercise, stress-induced left ventricular dilatation, as I said before, greater than 10% ischemic myocardium. And the rest can be found in echo and CTA. But if you can define this accurately, you will give your referring doctor a significant amount of information to work with. This is PROMISE, and I hesitate to present my perspective on this with Dr. Shaw in the audience, but this is a study that looked at coronary CTA versus functional testing to see whether CTA was associated with better outcomes in patients who present with stable ischemic heart disease, and you can see on the curves that they're identical, that neither test was better than the other. If you look at the secondary endpoints, one of the findings in the first row was findings of no obstructive coronary disease on CTA, and that was less, and on invasive cath, and that was less in the coronary CTA group. But if you look at the next three, invasive cath, revascularization, and coronary bypass, you can see that the incidence of events were much, much higher in the CTA group. Now, I don't necessarily attribute that to a difference in tests, but I attribute that to a difference in utilization of the test results. And I think it's very, very important for any of the tests that we do. We can talk a lot about ordering it for the right reason, doing it for the right reason, and doing it the best way. But unless we get our colleagues to use the results properly, we will not have effective and efficient care. So much of what I'm going to do now is just talk about some individual cases over the next two lectures. This happens to be a 57-year-old female who presents for evaluation of breast cancer. She had a baseline echo done, which showed an ejection fraction of 42% with regional wall motion abnormalities. She was referred to cardiology for, quote, pre-op clearance, secondarily for evaluation. Well, it turns out she's got a 24-year history of insulin-dependent diabetes and hypertension. She's on a variety of meds. She gets dyspneic after a quarter of a mile. She's mildly overweight. Her blood pressure is 140/70. We don't have her lipids, and her electrocardiogram is within normal limits. So if you wanted to look at this in a preoperative way, you can say, well, it's not really a high-risk operation. She probably doesn't need any testing for this setting. So the question then becomes, what do we really want to know? We don't really want to know if she needs a test before surgery. We want to know, does she have left ventricular dysfunction? Is it coronary disease? Is it hypertensive? Is it a stress cardiomyopathy from her cancer? Why does she have shortness of breath? Does she have heart failure? Does she have angina with an anginal equivalent? Does she have uncontrolled hypertension? Does she have metastatic disease? How do I treat this patient? These are the questions we want to know. And then, is it safe for her to have surgery? And if so, can she have chemotherapy? So that's really what we want to know. And the patient may ask those questions, but as a clinician, it's very important that we think about really all of this stuff. So it's really not so much thinking about the AUC, but it's really thinking about the patient and what the patient needs. And in this case, it's really a patient who had an abnormal cardiac test, and you're following up on that. She also may be symptomatic because she gets short of breath of walking a quarter mile. She only weighs 160 pounds. She really shouldn't have that. So if you look here, she's probably intermediate pretest likelihood of coronary disease. She has diabetes and hypertension. She has an EKG that's interpretable. She's able to exercise, but in this setting, both stress radionuclide imaging and stress echocardiography are indicated. We base a lot of our assessment of likelihood of disease based on what's called the Diamond and Forrester criterion. This has been around for about 20 years, and it's basically age, gender, and nature of symptoms. Typical angina is retrosternal chest pain brought on by effort or emotional stress or relieved by rest or nitroglycerin. If you have two of them, it's typical. If you have three of them, it's typical. If you have two of them, it's atypical. And if you have one or less, it's non-anginal. And based on this, we can really come up with our sense of pretest likelihood of disease. Now, this is not pretest risk of outcome. This is pretest likelihood of disease. The stress testing will tell you what the risk is. This assessment will tell you what their likelihood of disease is. So here's the exercise myocardial perfusion scan, and what you can see here, there's a significant reversible defect in the left anterior descending artery territory, apex, aneroseptum, aneroapical area, okay, infraapex. Her sum stress score is significant. Her transient, her ejection fraction is 49%, and she has transient ischemic dilatation. It's calculated at 1.2. And I want to just discuss transient ischemic dilatation for a minute now, because most of the time when you see transient ischemic dilatation, it's a technical issue related to poor processing, maybe poor images in the resting images. So whenever you see transient ischemic dilatation, even though your technologist processed it, you should look at it and reprocess again and make sure. So she underwent coronary angiography. She had a severe stenosis in her right coronary artery. She had lesions in her LAD and circumflex, and she underwent CABG. Her ejection fraction rose to 55%. She had her lumpectomy, she had chemo, and she had no complications, and her dyspnea that she had previously resolved. So here's the second case, a 63-year-old man with chest pain with and without exertion over the last month. He had defined coronary artery disease with a non-ST segment elevation MI 4 years ago, a disease in his LAD treated with a stent, and non-critical disease in the right coronary and circumflex artery. He was initially asymptomatic. He presented now with new symptoms that were slightly different. He was still on clopidogrel and aspirin based on guidelines at that time, and his physical exam was really unremarkable. In this case, myocardial perfusion imaging is certainly appropriate. Symptomatic patient, post-revascularization. His study showed a small area, decreased perfusion in the anterior wall, left over from his prior MI, no significant ischemia, and he was treated with medical therapy. The next case, I'm going to just skip that. So he presents 2 years later to reestablish care. And this time he's out of meds. So he's about 4 to 5 years from his prior myocardial infarction. He had an evaluation 2 years later that showed a low risk stress test, and now he comes 2 years later again. He's out of meds, he hasn't been taking it, he hasn't been going to the doctor. He wants to know if he needs to have another stress test, because now the insurance company will pay for a stress test. So when you look at the guidelines here, in an asymptomatic patient, it says you can have a myocardial perfusion scan if you're more than 2 years after PCI, that it may be reasonable to do. However, it doesn't say whether you could do it 2 years after that, 2 years after that, 2 years after that again. Well, when you look at the SCI, or Society of Cardiac Angiographers and Interventionalists, they now say don't do a stress test if a patient doesn't need a procedure. Avoid performing routine stress testing after coronary intervention without specific clinical information. So in this particular case, no testing was done, okay? He was started back on his medications. He had his blood pressure better control. We didn't know what his left ventricular ejection fraction was, so it would not be unreasonable to do an echo in that particular situation. This also is a very common scenario that we see. A 68-year-old male with renal cell carcinoma, history of hypertension and hyperlipidemia, evaluated for cataract surgery, normal electrocardiogram. We get many, many patients referred to cardiology for pre-op clearance for low-risk surgery. These patients do not need any workup. In fact, they don't even need a cardiac clearance at that time, but they certainly do not need stress testing done. A year later, he fell in the shower. He suffered a severe knee injury, hadn't been doing any exercise for 9 months, and gained about 10 pounds. He began to exercise and just noted some shortness of breath. His younger brother just had a cardiac arrest in a cabbage. Does he need to have any workup done? So he was referred for, in that particular case, an exercise SPECT MPI. He did 9 minutes of exercise. He achieved 10 minutes of exercise. His peak heart rate was 155, and he had no chest pain or EKG changes. Here are his images here, stress and rest images, and you can see they look relatively good. There's a mild reduction of counts on the inferior wall. I always say don't let a perfectly good stress test be ruined by a bad myocardial perfusion scan. Well, fortunately, we do prone imaging on everybody, and there's no reason why any lab could not do prone imaging. In the prone images, you can see the stress prone images. The inferior wall is normal, so we know that this is a normal scan and he's low risk. In fact, if you can exercise to 10 METs without chest pain or EKG changes, the likelihood of you having any significant ischemia is really very, very low, and this was reported by Jamie Bork from the University of Virginia at Charlottesville. Okay. One more case. A 77-year-old male began having chest pain after paving his driveway. His pain recurred frequently with activity. He went to an urgent care and he was advised to come to the emergency room. His electrocardiogram showed sinus rhythm with first-degree heart block and Mobitz 1 block, nonspecific ST changes. He has a history of remote tobacco use. He's limited in his physical activity by having knee replacements, and his initial troponins were negative. Here's electrocardiogram, which you can see the Mobitz 1 block on. So the question one would ask is, which is the best test to do? Simply a stress test, a stress echocardiogram, an exercise myocardial perfusion imaging, or a regadenoson stress, which I realize is not available in South America. But he's got bilateral knee replacements. It's unlikely that a 77-year-old can exercise to an adequate heart rate. Here are the contraindications for regadenoson: second or third degree heart block, sinus node dysfunction, but nothing about Mobitz 1 block. It's high degree AV block. So this person tried to walk a little bit. He really couldn't walk. Here's his myocardial perfusion scan with pharmacologic stress, and you can see here that he's got defects involving the lateral wall at stress that resolve at rest, some decrease in perfusion of the inferior wall, then improves. And looking at the polar plots, you can see that he has a very, very high sum stress score. And in fact, when you did coronary angiography, he had a very, very tight lesion in his circumflex that underwent PCI successfully that resolved his symptoms. Do one more case. This is a 56-year-old male with uncontrolled diabetes and hypertension who was referred for pre-op evaluation for hip surgery. He's asymptomatic but has low functional capacity. He's limited by his hip pain, not by cardiac symptoms. He's on medicine, so he was referred for a pharmacologic stress test. Okay? As you can see here in the appropriate use criterion, and we'll talk about that a little bit more later in the next lecture, but his functional capacity is less than 4 METs. He does have greater than 1 clinical risk factor, so stress myocardial perfusion imaging may be appropriate in this setting. Here's his myocardial perfusion scan. As you can see here, he's got a mild reversible defect in the left anterior descending artery. So the question is, what should be done in this particular gentleman? Should he have a hip replaced? Should he have a stent done? Okay? And the answer really is, because he did not have a high-risk findings, he should undergo surgery on his hip without any difficulty. And the most recent guidelines for coronary intervention look very, very specifically at the non-invasive test results. Okay? They look at anatomic disease, but they look at non-invasive findings. And it's very important, therefore, for you to be able to quantitate whether you're low or intermediate to high risk, because intermediate high risk is a reasonable way to proceed with coronary intervention. Low perfusion defects, less than 5%, less than 10% without transient ischemic dilatation should be managed medically. So, ASNC had done a lot to try and help educate. I've been working for the last 2 years on a project called Referring Wisely to help people understand the value, the role, and the best way to use myocardial perfusion imaging. It's a complex program that we have. One of the things that we have outside is a chart called Referring Wisely that's available for everybody to take home. We are working on trying to get it to translate it into Spanish and into Portuguese, but it really sums everything up on one chart. How to evaluate the symptomatic patients, pre-test likelihood of disease, and when stress testing, coronary CTA, and myocardial perfusion imaging would be the most appropriate, along with management. So this is something that, as a nuclear cardiologist, you could very easily send out to your referring doctors when they request a test, and you send them back the report. As I said, they're outside. Jocelyn has copies for everybody here who's interested. We have a case compendium of about 12 studies that are online that talk about very, very primary care focused cases to understand nuclear cardiology. We are adding Dr. Gabriel Grossman this year from Brazil, and we'll be having Spanish and Portuguese cases also on there. We have a variety of online videos, and we also are starting social media, which I really can't explain to you well, but Jocelyn hopefully will be able to explain it to you. But if you sign up for ASNC and Refer Wisely, you'll get tweets every so often about the things that we're putting out there. We finished the first 25, and we're starting up with the next set in the next few weeks or so with some infographics. So I think the vision of nuclear cardiology is that it's a valuable tool in the management of the worldwide epidemic of coronary disease. ASNC has been a leader to try and help educate and promote quality. We've defined the science and solidified the field by quality measures such as the appropriate use criterion. We've got a new proactive forward-thinking strategic plan that will help us move forward, and expanding access and utilization of MPI into developing nations is a crucial portion of what we want to do. So we thank you, and I'll be back to give the rest of the lecture in about a half an hour.